This audiocast will be dealing with two topics. The first is emergency contraception, and the second is venous thromboembolism in users of hormonal contraception. Emergency contraception is a topic that is of great public health significance given that there are over 3 million unintended pregnancies that occur annually in the United States, and that about 4.5 million women are at risk of pregnancy but not using a regular contraceptive method in this country. The areas that we will discuss, or the scenarios, are what options are available for emergency contraception, are there differences in efficacy, and are there factors that influence efficacy. The three major forms of emergency contraception utilized in the United States are listed here. Although the combination oral contraceptives, that is, those containing estrogen and progestin, were the first form of emergency contraception in use, they are infrequently used now due to their increased risk of side effects, particularly nausea and vomiting. All forms of emergency contraception are particularly efficacious. However, the copper IUD has the highest efficacy, plus has the added benefit of providing continuing contraception when left in. However, women with active sexually transmitted infections are not ideal candidates. Also, its use requires a procedure which will be uncomfortable for many women. Ella, which contains the ulipristal acetate, is somewhat more effective than Plan B one-step, which is the levonorgestrel preparation. And there's some additional differences as shown here. When you look at use within 24 hours of intercourse, the ulipristal preparation also does substantially better than does the levonorgestrel preparation in terms of reducing the risk of pregnancy. And this holds true also when use occurs within 120 hours of intercourse as well. When both of these preparations are used in obese women, that is, with BMIs over 30, ulipristal also performs substantially better than levonorgestrel. When you look at the risk of pregnancy, when further intercourse occurs during the cycle that the emergency contraceptive preparation is being used, ulipristal performs slightly better than does levonorgestrel. And importantly, in terms of side effects, particularly nausea, ulipristal also appears better. However, an important factor in the use of these preparations is what is the cost to women who want to use it, and it is here that levonorgestrel is far better from the standpoint of the usual cost of the preparation, particularly if a patient has to pay for this out of pocket. So, if we review what these three areas that we are discussed, what options are available for emergency contraception, levonorgestrel preparation, and the generic versions, Ella, which is the ulipristal preparation, and the copper IUD. Are there differences in efficacy? Yes. Clearly the copper IUD is far better than the two oral preparations. Ulipristal performs somewhat better than Plan B. And are there factors that influence efficacy? Yes, obesity, as we showed you, and the timing of the oral preparation, as well as further intercourse within that cycle, and also things like availability for the preparations. Though now there is certainly legislation that has made these preparations, particularly the oral ones, over the counter. The second area that we will be discussing here is the risk of venous thromboembolism among women using hormonal contraception. This is a topic that clearly has been extensively studied over the years. And what we will focus on is which hormonal contraceptives increase the risk of venous thromboembolism. Are there differences by specific preparations? What groups of women are at particularly high risk for venous thromboembolism with hormonal contraception use? Now, when you look at progestin-only contraception and venous thromboembolic risk, there's limited data on this topic. There's certainly no statistically significant increased risk that has been identified in any studies for users of the intrauterine devices or the implant. However, for a progestin-only injectable, that is Depo-Provera, there have been some studies, and a recent meta-analysis in the last few years did show the relative risk for users versus non-users developing an episode of venous thromboembolism was almost 2.5-fold. However, each of the individual studies in this meta-analysis had a small sample size, and the bias and confounding was highly likely. So the bottom line is that there's no convincing evidence of an increased risk of venous thromboembolism with progestin-only contraceptives. However, the CDC-MEC guidelines do recommend avoiding the injectable in women who have multiple risk factors for cardiovascular disease. So, again, no convincing evidence for increased risk of venous thromboembolism with progestin-only contraceptives, except potentially for Depo-Provera use in women with multiple risk factors for cardiovascular disease, such as older age, smoking, diabetes, hypertension, or abnormal lipids. Now, the venous thromboembolism risk with estrogen-containing contraceptives certainly has had a significant amount of study during multiple decades since the development of oral contraceptives. And again, it's clear that all of them will increase the risk of venous thromboembolism to women who don't use combination oral contraceptives. However, there's been interest in terms of whether the newer progestins have a higher risk than do the older ones. A Food and Drug Administration panel in 2011 reviewed much of the data, in fact had their own study that they completed, and they concluded that drospirenone-containing oral contraceptives and the contraceptive patch do have a higher risk of venous thromboembolism compared to the older agents, particularly those containing levonorgestrel, but overall the benefits outweigh the risk. A Cochrane review in 2014 of 26 oral contraceptive studies also concluded that compared to levonorgestrel agents, those using newer progestins carried a 60 to 80% increased risk of venous thromboembolism. However, a recent large German cohort study concluded no significant difference in risk among various progestins and oral contraceptives. However, I think it's this slide, which is from a ACOG committee opinion, that I think puts all of this in perspective. As you can see in the top of the slide, the risk of a blood clot per 10,000 women years in non-pregnant, non-users of combined oral contraceptives is somewhere between 1 and 5. If you then start using a birth control pill, you can see that that rate does go up to somewhere between 3 to 9 events per 10,000 women years. And it goes up somewhat higher if you're using drospirenone-containing oral contraceptives. But keep in mind, if you look at pregnant women, again, all of those risks, even if you're using a drospirenone-containing oral contraceptives, are substantially lower than the risk faced by pregnant women, particularly, as the last bar shows, women who are in the postpartum period. So although, yes, there's risk associated with the use of combination hormonal products for contraception, the issues that you're trying to prevent, that is pregnancy and its inherent risk of venous thromboembolism, including the postpartum period, are certainly risks that are substantially higher than the risks that occur with contracepting women. Now, what are some of the major risk factors for venous thromboembolism that go along with the use of combination hormonal contraception? Smoking and age 35 years or older. If these drugs are used in less than 21 days postpartum or 21 to 42 days postpartum in individuals who have risk factors, such as those on this list for venous thromboembolism. If patients have had major surgery with prolonged immobilization, again, whether this would be a routine cesarean section, probably unlikely, but it does increase the risk likely. A history of prior deep vein thrombosis or pulmonary embolism, and clearly these women would have a strong contraindication to the use of combination agents. Women with a hereditary thrombophilia, including antiphospholipid syndrome, certainly are not candidates for combination hormonal products. Women with inflammatory bowel disease with active or extensive disease or have undergone extensive surgery, immobilization, and so forth, also probably face an increased risk of venous thromboembolism. And again, the use of these agents should be done very carefully. And finally, systemic lupus erythematosus with positive or unknown antiphospholipid antibodies are at increased risk. Keep in mind, however, if these antibodies are not positive, the use of combination hormonal products is still okay. So in summary, which hormonal contraceptives increase the risk of venous thromboembolism? Primarily those containing estrogen and perhaps Depo-Provera in women who have increased risk for cardiovascular disorders. Are there differences by specific preparations? Certainly there is some data to suggest that users of the contraceptive patch and drospirenone containing contraceptives may have higher risk. However, these rates, however, are far less than that experienced by women who are pregnant or who are immediately postpartum. What groups of women are at particularly high risk for venous thromboembolism with hormonal contraceptive use? Certainly women with prior venous thromboembolism, older women, smokers, postpartum women, women with inflammatory bowel disease, and women with thrombophilias or antiphospholipid antibodies.